Good morning. Good morning.
Our responsibility is somehow gone.
All right. Thank you for coming back. Looking forward to another exciting session about the nexus and synergies that can be learned about from talking about health literacy and cancer care and cancer prevention as well. So in this session, we have a bunch of speakers who I will introduce in turn. First, we have Urmimala Sarkar, who comes from the Zuckerberg. That's, as she told us, you don't call it the Zuckerberg. I do. San Francisco General, from the General, which is what it was called for many, many years. Urmimala is Associate Professor of Medicine at UCSF and in the division of at UCSF in the Center for Vulnerable Populations, is a primary care physician at San Francisco General. Her research employs new tools such as digital and mobile health and social media to address and improve safety and quality of patient care. I'm going to stop with that because she's done a lot of other stuff, and hopefully she will tell us about it. Please.
Good morning, everybody. I'm delighted to greet the timely part of the audience today. Let's see if I can figure out how to advance my slides. I'm assuming green means go. The literacy of the AV system is better than most here. So one amendment from Michael's wonderful introduction, which is I am now a professor of medicine as of like 15 days ago. So, yeah. Thank you. What a nice audience. So I changed my talk after listening to all the things I learned yesterday. So I want to start by being explicit about what my context is for this talk. Some of the things that I took away from the first sessions, which were more broad overviews, in my view, were that the current health literacy demand of cancer communication across the continuum continues to be suboptimal. And I think the speakers in the first session did a very nice job of setting the landscape all the way from the initiation of this study to the present, demonstrating that we still have large gaps. The second session highlighted some literacy-appropriate approaches, mostly around more optimal communication and how it can be disseminated through training. And I think what I took away from that session is that there are evidence-based approaches that can and should be widely used. So on that backdrop, thinking as we did in the afternoon about new communication, there are some other highlights that I hope inform what I'm going to talk with you about today. So first, Dr. Chu talked about cancer misinformation's prevalence, and she also gave us a proposed research agenda that demonstrated the different kinds of research that need to be done to actually address this. And this is important because I think people think of misinformation as misinformation, ignore or address, and it's actually much more complicated than that. From Dr. Fitzpatrick, we got a clear idea of the continuing communication chasm between the public and scientists about cancer. And one thing I learned yesterday from the journalists on our panel is that I think of science journalism as something that bridges that gap, but there are in fact a lot of challenges in the way that it is currently structured, similar to the way that our health system is currently structured in a way that doesn't promote optimal communication. The structures around science journalism actually are not going to naturally fill some of the gaps. Dr. O from NCI suggested that some of the priorities for funding in this area include interventions to reduce communication inequalities. And some of the key parts of those interventions include the fact that they're multi-level because communication is occurring not only in the health system and not only in the public sphere and not only in the family, but across multiple levels. Using participatory methods, I think patient participation and inclusion was a major theme. The idea that we need to measure things besides efficacy, that we're looking at the implementation of communication methods, development, efficacy, and implementation in order to really advance the front line was important. And then my colleague at UCSF, Dr. Galen Joseph, she gave a couple of specific example studies that were really grounded in early methods of health literacy, content adaptation, use of audio, permission of repetition, visual images, to develop more literacy-appropriate communication. And I think it was a very elegant demonstration that these same core and fundamental principles are applicable to cancer and cancer topics. So with that background, I hope that I will be adding to the lessons from this meeting. Okay, so this is the National Academy of Medicine's list of characteristics of a health literate organization. And rather than going through these 10 somewhat wordy points, I want to talk a little bit about where we are with organizations and where we hope to go. So we can conceptualize it this way as these 10 points, or we can think about what's happening now in primary care. As I said a couple of times in my comments yesterday, I'm a primary care doctor. I take care of diverse and low-income populations with an extremely high prevalence of limited health literacy. And this is not any particularly cited conceptual model. This is my picture of what I feel like often happens in the office, right? So on the left side, you see the healthcare team has some information, then there's some communication process, some cognitive processing of that information on the healthcare system side. And then on the other side, your patient and family has a whole different set of information. They're doing some communication and having some degree of participation. And you have sort of the patient walking a tightrope between these two structures. Raise your hand if this resonates with any of you who've been in a physician office. Okay, so makes some sense. And this is where I feel like all of us in this room are trying to go, and that the 10 points that are enumerated about a health literate organization actually is just this. We'll all have the same information, patients, families, healthcare teams. Communication will be seamless and without gaps, and that seamless communication will allow shared decision-making to be built on it. And then the patient will be at the center of the healthcare team and the family. That's the vision of a health literate healthcare system. Okay, so when Michael asked me to give this talk, I wanted to go and look through what do we know about health literacy across the cancer continuum. And I'm not going to read this whole slide, but I do think it is important to touch on the body of evidence that's specific to health literacy and cancer. So in the area of prevention, health literacy and cancer-related knowledge are predictors for preventive behaviors, right? So this is really important. And I actually, when I send my slides, all the references are in the notes for my slides, so you'll have these at your fingertips. And these strategies of using plain language, teach-back methods, simple typography, and design have been employed to enhance understanding of cancer prevention, okay? Similarly, limited health literacy is associated with screening uptake, and employing effective communication can facilitate informed decision-making. And in the area of diagnosis, low health literacy is significantly associated with higher fears of progression. And during the treatment phase, literacy is associated with quality of life during treatment and having information needs met. None of this is surprising. But I hope it makes 2 points. One is that we're all having the right meeting, and this is something we should be talking about. But also, there's not really, in my view, a need to do further research linking health literacy to challenges anywhere along the cancer continuum. I think we heard a lot of personal stories and clinical stories yesterday that suggest that health literacy impedes cancer communication along the continuum. And what I hope I'm showing you here is evidence that links these two concepts. So now I feel like we can accept that and use it as a basis for developing interventions. So across literacy levels, for survivors, there's a need for more appropriate information. And a recent study of end-of-life care, which was extensively discussed yesterday, as it should be, found that Among online articles written about palliative and end-of-life care, none of them were written below a 7th grade reading level. So there is a real, and we talked a lot about the need for the lay public to understand palliative care. There is a real need and gap in terms of the literacy of what is written about palliative care. Okay, so this is from the Lost in Transition report from 2006, from what was then the IOM, and it describes the end of treatment consultation note. As you can see, it's quite technical in its language. So I'm going to give you a case example now from a study that I recently did with a postdoc who's a sociologist by training. Yesterday, we alluded to survivorship care plans. These are documents that are intended to live with patients and carry critical information. As alluded to yesterday, they are required for accreditation. They have unclear efficacy in practice, and there has been much written about the challenges of implementing them and also their effectiveness or lack thereof. There's also unclear extent to which these have been usable or tailored for diverse populations. So we did a study of survivorship care plans. And I'm telling you this because I'm hoping that it illustrates where we need to go with literacy and survivorship. Okay, so we collected 16 survivorship care plans by calling up a whole bunch of cancer care providers across the state of California in the safety net. We used the methods from a prior study that looked at concordance with the Institute of Medicine recommendations, and we went through a checklist of did these survivorship care plans contain what they were supposed to. And then we looked at, and then we reported like what proportion of the recommended elements were included. And then we also used a well-known communication standard called the Suitability Assessment of Materials to assess whether patients from diverse backgrounds are likely to accept, understand, and use the plans. This is an instrument where you have a set of criteria and then people grade the written document with a numeric score. So 70% and up is superior, 40% to 70% is considered acceptable, and not suitable is less than 40%. So there is a subjective element. That's why you need to have 2 raters for this scale. And I just wanted to show you what some of the example survivorship care plans look like to ground you in it. So on the right, you can see the survivorship care plan from San Francisco General Hospital, which is in English, Spanish, and Chinese, which together constitute the language preferences of about 90% of our patients. Okay, so the majority of plans didn't have everything they were supposed to have in them. The average reading level was 14, and only one plan received a superior rating for cultural appropriateness. Right, and from my understanding is this is the one written document that is required by accreditation for patients to take home in their hands. And in practice, it is not responsive to all the things that we know from the literature are out there about the communication needs of cancer patients. Okay? All right. So my conclusions are they don't work and we need to rethink them. I promised Michael that I would have some concrete recommendations about health literacy and cancer communication. So here are a few that are specific to survivorship and also more broad. So it's time for a re-examination of the intent of survivorship care plans. So one idea of them was you're leaving your oncologist and your primary care physician has things they need to know. As a patient safety researcher, I really believe that the answer to that lies in electronic structured communication through electronic health record interoperability. When I say that, people always say, that is a dream, that is a pie in the sky. It is not. It is a policy imperative. Physicians need to be able to look at other physicians' records. Okay, I think that back in 2006, that wasn't even conceptualized in the IOM that we could actually expect that. Now that 90% of physician offices are on electronic health records, we need to think about that primary care physician oncologist communication as not having to be patients' responsibility. Okay. That isn't to say patients don't absolutely need to have a treatment summary, but the level of detail that is absolutely necessary for patients to have in their hands isn't the same as what I need as their primary care physician. So let's acknowledge that and think of those separately. Nobody has a piece of paper to do anything important in their life anymore, right? I mean, banking, socializing, working, everything else happens through interactive online communication. So I propose to all of you that there should be interactive online communication. When someone finishes their last chemotherapy treatment, it is not the time to tell them about late effects that are going to happen in 7 to 10 years. What if we told them what they needed to know now, and there was a place that they could find what they needed to know later? Overwhelming people with excessive communication is just as ineffective as not giving them the information that they need. I agree with Michael's opening statement that we're not talking in this meeting over a day and a half about better brochures. However, I think we should talk about better brochures for 1 minute. Okay, there's no point in giving people things that they're just going to put on their counter when they get home. So there is a way. People do read some things. Let's take, Dr. Lazard's work from yesterday and make our materials engaging for people so they look at our things. And then I do really believe that in the same way we need to increase the incentives for palliative care conversations, we need to increase the incentives for providers to engage in optimal communication practices. Pay people to go to those trainings. Pay people to answer secure messages. In one of my studies, we looked at the literacy level of communication in secure messages. And you know what? Providers are not good at matching patients' literacy levels in written communication. But some of them are, right? There's a range. So it can be done. It just takes more time. And we need to recognize that and actually allow physicians to be compensated for doing a good job. And then finally, it's not all about the doctors, right? So can we do more team-based communication? And finally, I'm going to make a plug for peer-to-peer communication across the cancer continuum. I think it is critically important for those with limited health literacy. And I'll stop there and look forward to the Q&A. Thank you.